Hello, my name is Dr. Kathleen Callaghan. I'm an OB hospitalist. I work with the OB hospitalist group. I am currently the market medical director as well as site director in the state of Texas. I am working currently at two hospitals in Texas. I am going to tell you a life-safe story that occurred on one of my most recent shifts at one of those hospitals in Texas. On a Sunday morning, we got a call from EMS. A patient was being brought in with a history of 3 days of vaginal bleeding. We knew that she was term-ish, but we didn't actually know how far along she was. We knew that she did have a private physician. That private physician's hospital, though, was not close to where the patient was picked up. So the patient was brought to our hospital as we were the closest hospital. When she arrived, the patient was deemed hemodynamically stable. She had normal blood pressure. She had a normal pulse. We immediately put her infant or her fetus on the monitor, and we had a category 1 tracing. We did notice that the patient was having vaginal bleeding. She gave a history of seeing her physician approximately 3 days previously in the office and told us that she was 3 centimeters dilated, had been sent over to the hospital for an evaluation, and then discharged. She went home and subsequently developed vaginal bleeding off and on for approximately 3 days, and that's when she came to us. The patient also reported that she'd been having an unusual amount of abdominal pain throughout her entire pregnancy. She had 2 previous cesarean sections, but an otherwise uncomplicated course during her antepartum time. She had a starting hemoglobin of 9.3 when she arrived. Because of the vaginal bleeding, we also ordered a CBC. We ordered coagulation studies. We saw that she was contracting approximately every 4 minutes. We did not believe there was a previa. She gave a story of previously being checked by her physician only days earlier. We did check her. She was about 4 centimeters dilated, about 70% effaced. And again, we looked at the tachometer, didn't appear to be any type of abruption pattern, and she did not have a tender abdomen. We didn't feel that she was currently abrupting, but it certainly was very high on our differential diagnosis. Because the patient was stable, we felt like we wanted to move back to the operating room fairly quickly and keep this the way it was, a stable mom and a stable baby. Of course, we alerted the NICU. We found out that she was 35 weeks, 4 days. This was a G3P2, 2 previous cesarean sections. We have a system at OBHG where we have a backup physician on call in case of emergency. This was a Sunday. We did alert our backup physician, who is on standby approximately 10 minutes out from the hospital, in the need that they would be required. We knew that they would be able to come fairly quickly. We proceeded to notice the patient's blood pressure was slightly elevated, about 146/70. So we went ahead and ordered a preeclampsia workup as well, just to be safe. We got 2 lines, 2 large bore IVs started just in case there was a need for blood transfusion. And then we also had 2 units of blood on hold in the blood bank. We did go ahead and bring the patient back to the OR. She remained stable. We were able to place a spinal. The patient did mention that she wanted us to tie her tubes, but we felt probably not a good time to be doing that with a preterm infant on the way, and she seemed to understand. We proceeded to begin the surgery with myself and a scrub tech. We went through her previous fan and steel incision, as we usually would, and as soon as we got to the peritoneum, we just opened it, slowly at first, and this is where the surprise begins. When we opened the peritoneum, there was an enormous amount of blood in the abdomen, and it was actually actively bleeding. The blood was actually so voluminous that our first thought was, we need to get this baby out. So we did expand the peritoneal incision as fast as we could, and that's when we noticed that there was some type of placental abnormality. Placenta percreta is the first thing that came to mind. I could barely see because of the large amount of blood flow coming from this placenta in many places, but I was able to take my hand and traverse not through the placenta, but around it to get to the baby's head. The incision certainly was not just a scar on the uterus, it was more of a fish mouth. The placenta had grown out and the incision had been open for some time, and the placenta had grown out and attached to the omentum as well as the bladder. But we were able to get my hand in there, get the baby's head out. There was a double nuchal cord, which we reduced immediately, and we were able to deliver the baby safely. The amniotic fluid was actually clear, believe it or not. NICU was right there. We cut the cord. We took the baby as fast as we could away from the situation because the bleeding was so profound. We immediately called a massive transfusion protocol overhead to alert the entire hospital that we had an emergency situation on our floor. The AOD responded immediately, as did the nursing staff. We brought the rapid transfusers in. We got anesthesia to come and have a second provider immediately, even though we had 2 lines started and the patient got TXA preoperatively. We had an additional art line and an EJ inserted as fast as we could. We did put the patient to sleep immediately, and we ordered blood. And so that was on the way. In the meantime, because it was so difficult to see because of the massive amount of blood loss, we were able to pull the uterus out and to get a better perspective of what was going on. In the meantime, I had called my backup in, so she was on the way in. And then once we saw the amount of invasion into the bladder, we also called for the gynecologic oncologist. So I had nurses on the phones trying to get a hold of him as well. So what we did was we pulled the uterus out to get a better view. And what we did is it attempted to see where is this placenta, because it was up here, it was down there in the bladder, but we tried to remove some of it. And what we noticed is the uterus is very atonic as soon as we pulled it out, but we were able to scoop out the top portion, kind of near the fundus and the anterior portion. And as soon as we were able to pull that part out, the part that was stuck was actually embedded in the incision. Thank God there was no previa, and it didn't seem to really go down into the cervix too much, but it did invade into the bladder. So what I did is we went ahead and administered Hemabate to try to get that uterus to clamp down to increase the patient's volume. Her blood pressure was dropping quickly. They were pulling from her art line the blood gases that they needed to administer the appropriate bicarbonate and calcium, and to try to keep her stable. At one point, her blood pressure was literally 30/12. We resuscitated her with blood products, including packed red blood cells, FFP. She got albumin, she got IV fluid, you name it, she got it. She got cryo. So we actually kept her remarkably stable initially when there was the massive blood loss, but she did end up going on a levo-fed drip, more towards the end of the procedure. However, we were able to get most of the placenta out. We realized that we had to do a hysterectomy. I was able to start the hysterectomy with the ligature device. We were able to get the round ligaments, my side, and then I was starting on the other side when my backup came in. She finished her side. We did a subtotal hysterectomy, and then we realized that, all right, thank God we've got the cervix here, but then we had the bladder to deal with. The placenta had really invaded most of the dome of the bladder. Our oncologist, our gynecologic oncologist, was on the way in, but it just seems like, time is going by and they just, no one ever gets there fast enough, but he got here in a very timely fashion. We had to make a decision because of the massive amount of blood that was still occurring to take off the dome of the bladder. So we used a ligature device for that, and then we clamped everything else. Just at that moment, the gynecologic oncologist walked in. We all agreed on what the anatomy was. Because the dome of the bladder had been removed, we had great visualization of the ureters, of the ureterovesical junction, so we could see, we knew we were clear. We all did a thumbs up, and together we closed the cervical stump and the dome of the bladder together. And so we ended up inserting a JP drain in the end, and she basically stayed pretty stable. I mean, the entire surgery, and never went into DIC, which is totally amazing. But again, she went to the ICU on a levo-fed drip, but she did remain stable. So we went ahead, finished the surgery. The total estimated blood loss was 11,000 cc's. We replaced her complete body volume of blood twice. But she was in the ICU for about a day and a half. She was extubated after 24 hours. Her only complication was that she did develop a right DVT in her arm as a complication from the massive transfusion. She was started on heparin, of course, and then we transitioned her to Eliquis. She did well. She went home on post-op day number 5. She left the hospital with a hemoglobin of 8.2, received 10 units of packed red blood cells, 5 units of FFP, plus some cryo and albumin and IV fluids. It took a village to save this woman. Everyone contributed. Every person played a key part in saving this woman. Her baby had APGARs of 8 and 9 and was ready and waiting for her in the room, and she left the ICU. She was grateful. She had no idea that she had this disorder with her placenta. She did tell a story that she had seen one doctor previously who had told her that her placenta was low, but then when they did another ultrasound, it had moved out of the way. And apparently no one was actually looking at the other part of the placenta that was growing up into the muscle and, out into the space it should not be. So the pathology report came back. It was a confirmed placenta percreta. So this woman did want her tubes tied, so she certainly wasn't upset when we told her that her uterus was no longer there. We were able to save her ovaries, of course. And this is such a great story because we talk about why is it important to have a first responder? How important is it to have a OBGYN who's trained in emergency situations on that floor? I think this is such a great example of not only just having someone there, but having someone or a team that feels comfortable in these, knows, it's go time. Everybody play their part. And we did. And yeah, it is sometimes in the middle of it, it seems like organized chaos. But in the end, and you look back and you do your debrief, we're all proud of the work that we did. And it's an honor and it's a privilege to be a part of OBHG and to be able to deliver this kind of service to every woman, every single woman. It doesn't matter if she has care or doesn't have care, has a private physician or not. It doesn't matter. It's in the moment, having that opportunity to step in and do the best you can possibly do. And the only way you can do that is to be there. And that's what OBHG does. We're there.